If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today I'm joined by Dr. Brian Wolfe, a doctor of physical therapy who co-founded Evolution Physical Therapy and works with professional athletes at New York City Football Club. In this episode, we're talking about back pain. What's actually going on with your spine when it hurts? Why fear of movement is often the thing that turns an injury into a chronic problem. And how to build real, lasting resilience through progressive strength training. If you've ever dealt with a stiff back or a full-on disc injury, or you just want to keep your spine as healthy as possible for the long haul, this conversation's for you. Let's get into it. Today, I'm so excited to welcome back Dr. Brian Wolfe, my good friend. We worked together back with New York City Football Club. We did some great rehabs together. And one of the reasons I wanted Brian to come on today to talk about back pain is because he has done rehab on both me and Michelle for our back pain. Brian, welcome back, mate. I'm so excited for this conversation.
I love it. It's funny you say this because even NYCFC now in general, I feel like this is my wheelhouse. Back pain is what everybody seems to gravitate towards me for, which is a good thing. It's great.
Yeah, exactly. This will be a great conversation then.
Yeah.
So we had to switch gears pretty quick because we just started doing the episode
exactly.
offline. I just want people to have an understanding of, first of all, the spine, the anatomy in general, top to bottom. I want to talk about movement and fear and anxiety around back pain. You know, for me, back pain, it's common, it's confusing, and it's often exacerbated by fear.
Yeah, for sure.
And the fear, I think, is what makes it become chronic, where we own this bad back, right? I had one injury, and then for the rest of my life, I got a bad back. So I think it's a bit different than a lot of injuries in that regard, that we don't move on from it. And so I really want to get into that conversation today. So can we start with just having a look at, how does the spine move? If we go cervical, thoracic, lumbar, and we go down through sacral, we've got regions of stability, rotational, flexion, extension. Which zones in our spine, or which areas of our spine are supposed to move in what ways?
So it's a great question, right? And a loaded one. And I think to first start with this, I think that's what creates the confusion. The first thing, say you and I are having the same conversation on shoulder pain. Okay.
Yeah.
It's a ball and socket. We can visualize it. It's one joint. We can look at it from a articular perspective like this. We can say, okay, if it moves overhead, it moves this biomechanically. If we move side to side, right? If I move across my body in horizontal abduction or adduction, it moves in that direction. If I go backwards in the extension, right, we can conceptually look at the one joint and look at individual movements. You can't do that with the spine, right? And you just named another one, which is the sacroiliac joint. When you think about the cervical spine, where you have 7 levels, right?
And so that's the neck.
That's the neck, yep. Then you got the thoracic spine, where you got 12 levels, which is the mid back, right? And then you look at the lumbar spine, where you have 5 more levels. There's your low back. And then you have your SI joint, which, that's an interesting piece because I think that's been convoluted for a long time in terms of at a place and blah, blah, you hear this stuff going on. And so if the reality is all of those levels, so if I have C1 and C2, so cervical spine 1 and cervical spine 2, right, along with the skull, we didn't even talk about that. That's one joint. So if you consider this as a whole, you have multiple joints in every direction, right? And every single one of these directions moves in 3 planes of movement. So you flex and extend, right? You go side bending, right? Side to side, and then you rotate. right?
Yeah.
And we didn't even talk about shifting, because the spine does shift as well. So technically, well, if there was a fourth degree of movement, you would think about the
So
shifting.
now we go side to side.
Exactly. The dance move, right? I was joking dance move.
Yeah.
But when you think about shearing, that has to work as well. And that is in all those different planes. So a different effect. The spine also takes compressive movements, right? And one of the biggest farces I tell most people is the thought process behind the disc is that the discs of the spine are the shock absorber of the spine, which is right, but it'd be the equivalent of me saying that when I slam on brakes, like the brake pads are what stop the car, right? Like the answer is the discs clearly do a shit job of doing that. Otherwise, we wouldn't have disc bulging and herniations.
Yeah.
80 to 90% of the population, right? The legs are meant to do that. And we'll touch more on that as we go into jumping and so forth. So when you think about the anatomy of the spine, you have what's called a lordosis. So we all have curves. So we stand up nice and tall. If you Google a picture of a spine, we'll see the lordosis in the cervical spine. We'll see the lordosis in the lumbar spine, and then a kyphosis, so the other curve in the opposite direction of the thoracic spine. That's designed to be better for compression.
Right.
The idea behind that is if it was a straight line, if I were to take it off of tilt, think about it.
If it's like a rod.
Gravity. Yes, exactly. If it's a rod, it doesn't have, it's going to be much stiffer, and particularly in the two endpoints. So if you think about the beginning and the end of it, right? So a rod, like people might say, oh, well, that's stiffer. Well, yes, but that's why we also have to be able to move. So it's got to be able to move and rotate, along with the fact that it's got to be able to be compressed. Now, here's the other aspect of it. And again, this is, by the way, this in itself, I probably could just ramble on for hours and hours and hours, because the reality of it is it's a very complex structure, right? It's aspects. So I'll try and, be as succinct as possible. But the other aspect is from an evolutionary perspective. Remember, we were horizontal. The way that our body took pressure was not through the skull downward through the feet, right? We were on all fours. So when you think about the spine in general, it's now being oriented against gravity a different way. So that's important to respect and understand. And so particularly whether it's an athlete, older person, right, wherever, or anybody in between, it's going to matter. So the idea behind the cervical spine is all the cervical, thoracic, and lumbar spine and the SI should all do these different movements and should all act as joints. We look at them independently, but also interdependently. So they need to also interact properly. So when we think about flexion, and the way that we move forward and bend forward, the way that we extend, the way that we rotate, the way that we then side bend, we can look at where those primary movements should come from.
Right.
The general thought process that I have heard for most people, I shouldn't say this, I'm gonna say this, but this is where I could be challenged, and I would not die on this hill, right? Is that the primary amount of
rotation to the comment section?
Exactly. So I'm all about warning in the comment section, and would love to talk about it forever. The main part of the motion with cervical spine is generally rotation based, and the reason I would say that is because you can get so much rotation in the cervical spine, right? You can't necessarily get 90 degrees of rotation anywhere else. So if you think about 180 degrees left to right, generally speaking, the primary motion of rotations in the cervical spine. Side bending is more in the thoracic spine, and then flexion extension is more in the lumbar spine. Now, again, the reason I would say you could be challenged me on that is someone could argue, but all of them do all 3 degrees of motion. They would be completely right? Kind of, I'm contradicting myself by saying that.
Yeah.
But the reality is also you have to pay attention to how it does those things and to what intensities and degrees. To me, when we look at the discs of the spine, the discs are in between each vertebral body. So, when you look at the facets, the idea behind the way that the vertebral height is created is through these vertebral bodies. Then we have facets on either side, a right and a left, and then you have a spinous process in the back. And then there are basically, I don't want to start getting overly technical, but the dorsal and ventral rami are where the nerves exit in the front and the back of the spine that essentially give sensation and motor control.
Yeah.
Then you have discs in between in all these areas. And again, those rami come off of the spinal cords. The spinal cord sits where it sits behind the vertebral body and in front of the spinous process. And then you have discs in between each level of these vertebral bodies. Right. So again, you've got, and then here's the kicker. This is a very highly innervated structure. I tell people all the time, right? So when people are like, but I don't have a disc bulge on an MRI. Why do you think it's a disc? And I'm like, because it's not that bad, probably, right? Like in general. Right. But why do I have a lot of pain? Because this is again, like you have the brain, the spine. This is the central nervous system and parasympathetic nervous system hub. So in essence, if you've got a lot of pain here, and this is where we go into the own your bad back, the anxiety,
Yeah.
blah. Someone says, well, there's nothing wrong with you. And then if you really want to get into some of the psychological aspect of that is, now is there something wrong with me because I'm thinking X, Y, and Z and no one's hearing me, so I got to scream it louder.
Yeah.
So that's a whole nother pain sign. So I know we can keep going. I could go forever on it. So you stop me as we go. But that's
I think that's a really good overview, because the other thing I want to say about that is why is this not showing like on the image? There's also not a lot of space in there.
Yes.
Right. You don't have to have like a complete prolapse of that disc for it to be touching something that's going to cause you pain.
Yes.
The other thing I want to say on that is that, as you and I know, when we deal with pro athletes, we're very judicious on who we do MRIs on and who we don't.
For sure.
Because me and you and every other human on the planet, we could all MRI our spines. 50% of us will have bulging discs, 50% of us won't. And who has pain really has nothing to do with either of them. Right?
For sure.
I think that's really important, just to get an understanding of the anatomy and what structures are going on there. And that helps us to start dig into, okay, well, let's talk about this, about pain and where it might be coming from. And we've all, if you're over 30, woken up and your back's just stiff.
Yep.
Or if you're standing for too long, sitting for too long, you go on a long drive, we have a stiff back. Even that people can start to own a little bit. Like, oh, I've got a sore back, right? I've got a bad back. So where would you think things like that rather mild, I'd say, back condition, where do you think that's coming from? And, can you explain a little bit about that for us?
Great question. So I think that, and by the way, in all of that explanation and rambling I did for 10 minutes probably, Jez, right? That whole thing of that. Not once did I talk about musculature, right? Not once. And of course there's loads of muscles that are supporting small rotatory movements, small side-to-side movements, big movements, and so forth.
Yeah.
In all directions.
Yeah.
So when you talk about pain, I think the biggest disconnect that has really changed the game for me in my practice of how I treat back pain and neck pain, and quite frankly, all pain in general, is to respect the fact that it needs to be its own category of treatment. Meaning, if I look at a spine and I say there's a discogenic problem, to a facet problem, to and again, so say I have another clinician, whether it's a chiro, a physical therapist, an athletic trainer, someone disagrees with me on my diagnosis of what they believe it is. I go, okay, no problem. So what are we doing to address this pain first? If we're going to address that pain first, let's peel that out and let's address the pain. Because if we can agree on we've got exercise or different things we can do to address the pain, we now understand that maybe they're connected to the problem, maybe it is not, right? The second part of go ahead.
That's a really important point there, Brian. We just did an episode with Dr. Paul Hansma. He's a researcher in chronic pain and pain science, and his point was really interesting in that yes, that pain is a separate issue in itself, and it's actually more of a cycle where it's stimulus and then fear, anxiety, and stress. And,
for sure.
And that's a feedback loop that keeps going back around and around. Most of what we focus on is the stimulus.
Yes.
We're doing exercises, we're doing massage, we're doing injections, we're doing all of this stuff over here, but nothing to address the fact that you feel the sensation and then you get anxious and fearful and stressed about it. And so he actually puts more emphasis on, let's deal with this side of it. Because we're already stretching and doing all this other stuff. And mostly it's probably not to do with the stimulus, especially as it starts to become chronic pain.
I totally agree. And I think one of the things that people don't give enough credit to is this idea that there is a pain cycle that we need to break, to your point.
Yeah.
What you're talking about is and let's even take the psychological side of it. I have pain in my back, right? So I wake up stiff and I go, oh, what is that? What's causing that problem?
Right.
I don't understand what's going on. So because I don't understand what's going on, I can't really do anything to relieve it. Well, that creates an increase in anxiety in general, fear, anxiety around movement. Okay, when I move this way, it hurts more. When I don't move, it doesn't feel good. If I sit still, I feel better than if I move, right? And why is that happening with my back? Now, On top of that, say we then introduce the idea of you make a movement that hurts. Now we think, oh God, pain makes it worse. And then if I go to a physician or I go to somebody who says, hey, just rest, well, guess what? Now I've just had confirmation bias on that front. And now all I've done is reinforce that curve, to your point. And so the outside stimuli, if I move in this way and it causes an increase in back pain, is also negative. When in reality, there truly is this idea of how can I move a little bit better? And if I move better in X, Y, or Z direction, I'm actually going to adjust the pain or the problem or both. And that is a gigantic part that you're talking about, the stimulus. And that's where I believe the central nervous system plays a massive role in the spine when it comes to pain. So to me, when it comes to that concept, I totally agree with you on the chronic pain side of it, is understanding how the stimuli work, understanding how this pain cycle comes, and you have to break that first. Because if you don't break that pain cycle, and by the way, you can meet people in so many different places on that, right? I'll give you a great example. I have a patient right now, and this always shocks me. They had back pain or they had something along those lines like that, where in essence what happened was she was like, I have this back pain. And I go, what have you done for it? And she goes, nothing. I've done nothing for it. And I go, when did it start? 10 years ago, right? There's the classic line. I'm like, what the fuck? It's like it happens. It's like, okay, well, so you've done nothing for it. But in her head, as she kept talking to me, one of the things she kept saying to me, she goes, something's out of alignment. Something is out of alignment. I got to get it back in alignment. And listen, this is also one of the misnomers, is that there's not like stuff's being in and out of alignment. Again, at the spine, if one of the joints was out of alignment, you'd be a paraplegic. That's the right time.
Well, talk about those small spaces, right?
Yeah. We're talking millimeters here, right? Like to your point.
I literally had somebody who I was working with, that a practitioner told her that one of her cervical vertebrae was backwards. He was like, it's literally backwards. I'm like, well, it's literally not. It's literally not.
That's impossible. That comes from an aspect of, it's a training side that has been debunked in research, right?
Yeah.
And what's happening is, and it's not to throw shade on chiros, because I work with a lot of great chiros, and manipulations and adjustments are great, but it comes from this idea of like, you hear this crack because I'm putting something back into place. Well, we know we're not actually doing that based off of research, right? It's the same exact concept when someone yells at me about press ups and so, well, you can't put the jelly back in the donut. Like, that's been shown too. It's like, totally get it, but repetitive movements in certain ways are also shown to desensitize the central nervous system. So therefore, if you look at it just from a perspective of repetitive movements help pain reduction, we are probably moving something on a pain science scale. And so when you think about the concepts of that, like you point about literally backwards, like I don't even know how people can continue to justify some of that stuff, but I think in general, the bigger thing that I would say for anybody who's waking up with like the stiff back, like you're talking about, the first thing I would look at is, okay, don't fear. That's a normal thing. And actually moving should make it feel better. Right. Like, that's the biggest thing. And honestly, I'm a big believer in, it's a disc until proven not guilty. I'm not suggesting that it's always discogenic back pain. I think you've probably heard me say that, Jeremy, like in the past. It's a disc until proven not guilty. And so the idea behind that is discs are always stiffest in the morning. Right. So hence why people have usually back pain in the morning and they feel better as they move. That's pretty much a gigantic indicator that movement's going to be helpful. And the reality of anything and any joint nutrition is, if you move in all degrees of motion at end ranges, you're going to increase the nutrition to the joint at the best possible cadence. And so to me, that's a huge piece that I think is super important, that people need to understand. So whether it's extension, neutral, like one of the rehab process that I've seen a lot of people do is go, well, you have to strengthen in core and spinal neutral. But if you do that too early, you haven't restored all the motion. It'd be no different. It'd be no different than if I just said, hey, I'm just going to do wall sits all the time. Yeah, you'll get stronger, but you're leaving
in
so
that
much
very specific space.
Exactly. You're leaving all this other range of motion, like that'd be the equivalent of eliminated squats, terminal knee extension, right? Long arc quads, like all sorts of other things that we can add into functional spaces. And so, that to me is a huge piece of the spine in general, of what more and more people need to do around back pain, is like, think about how that's, and then on top of that, then you want to identify, are people too mobile? I was texting with the sports med doctor today, where she was joking about how she was like, she dislocates during surgeries, which is cracking up her fingers, right? And then she puts it back into place and she moves on with her surgery. And so it's like, that's her normal, but strengthening is going to be the name of the game, not stretching.
Yes.
So when she wakes up stiff, The idea there is we know this, we want to do more strengthening, and that stiffness should restore. And that's a pain science concept. That's not a stretching concept. On the flip side, the person who's super, super, super stiff and lost range of motion, they go to yoga and get incredible pain relief.
Yeah.
Right. And so you see that work.
It's interesting because I've got one of those hypermobile clients, has back pain, and it's a really interesting one because when they feel stiff, they feel tight.
Yes.
And it's funny. I always laugh because I'm a pretty stiff guy.
Yeah. Yeah.
So she's like folded over double and talking about how stiff she is. I'm like, okay, well, objectively, no, you're not.
Yes, exactly.
And so it's a really valuable point there. If you are one of these hypermobile people, don't immediately default to stretching. If you feel tight, default more to activation and strengthening.
Yes, 100%. This is actually why I really like SFMA, because I feel like it can show a lot of people to a degree how to move in those ways. I have my qualms with it as well, but I think in terms of like the ability to look at somebody in general, right? So say I'm going to do a rehab where if I say bend forward and touch your toes, and they can put their palms on the ground, right?
Mm-hmm.
My first reaction is, and can stand up beautifully from that position, which, to that person who generally, like you're talking about, generally what I will see is they'll be like, oh, look, I feel stiff. And they'll put their hands on the ground, flat on the ground. And they'll be like, I feel stiff. And then what you'll see is they'll stand up and sort of hit that lordosis really fast.
Yeah.
Because what they're doing is they're trying to lock out their spine before they get all the way back up.
Yeah.
That's an indicator of that stability piece, right?
Yeah.
If you watch them then slide themselves up their body, or they walk their hands up their legs, same kind of thing. They're just trying to create inorganic stability somewhere.
Yeah.
Same thing with incredible muscular tone in those areas too. So now what it shows is here's this tone that you're creating that's basically creating this chronic, and again, that's why you feel stiff in the back pain and the musculature, because what's happening is these muscles are working overtime. I tell people, it's no different than if I put a 5-pound dumbbell in your hand and I said, hold this bicep curl at mid-range, and you just hold it ISO, right? If I did that, you'd sit there and you'd look at me and you'd be like, well, this is fine now.
Yeah.
But talk to me after 48 hours, right?
Yeah.
Right?
Yeah.
When you go to move out of that position, you're going to feel like you just got your arm out of a cast for the first time.
Yeah, exactly. And real quick, just explain SFMA for the listeners.
Yeah. So it's just a movement concept, like a functional. I'm gonna butcher it. And my apologies to SFMA community because someone's gonna kill me on here. But systematic functional movement assessment, something like that. It's some along those lines. Just another continuing education course. They do a really good job with how they select movement. They look at different. They do a great job, in my opinion, of picking an algorithm where it's like, I look at forward flexion, then I look at rotation, I look at extension at multi-levels. So not just the cervical spine, the thoracic spine, the lumbar spine, the knees, the hips, the shoulders. Like they do a really good job with their screening and how they break and then they call them their breakouts, where they break out different movements. And I think that's also great. One of the things I love about that, and we can talk about as well, is when you talked about the SI joint. We didn't even talk much about that, but I think I personally think that's a thing that gets a little overdiagnosed.
Mm-hmm.
In lieu of like discogenic stuff.
Yeah.
SI joint pain, is thought of, like to your point about my cervical spine was rotated backwards, right? The SI joint itself, they look at, this is rotated. This is extended in a different position, or this is flared, or this moves.
Mm-hmm.
This is a joint. It's a joint that moves in 3 degrees of motion, right? It slides up and down, it flares in and out, and it rotates. And so most people lose range of motion via research over as they age. They see this as about 15 degrees of play, and then you get stiffer as you age. Just a normal aging process. And the reason that whole occurred of like, there's an anterior rotation, there's a posterior rotation, there's a flaring rotation, was because of some outdated research that's been debunked. And so what ends up happening is, you look at a leg length discrepancy, you look at this and you say, this is how this works, and we're going to move it. And that's something that's also been changed. So again, sometimes it's bringing it back to some basics. I think SFMA does a great job of that personally. Because then I look at low back pain as a lumbo-pelvic spine and hip issue. And I think that's a great way to look at it. So you can also tie it all together that way as well, which is fascinating.
So these are all such good ways to start picking through where your pain might be coming from. But we've talked about the stiff morning back. Let's talk about the events, right? My back went out. And again, we'll continue on the theme of a continuum where I've had it, where when we lived up in Toronto, and the first day that's like above freezing, you're out in the garden trying to like just get in the first sun rays of the spring, and you go to pick up the bag of soil that you haven't picked up for the last 6 months, and you get the tweak in your back, and things lock up. You start to want to not lean forward, so no radiating pain, no electric shocks, anything like that. It stays pretty local. And then we go all the way up to the full on 220 volt down the leg. You're on your back and in excruciating pain. Yeah. And I've had clients where I've arrived basically on the scene, as it were, the same day, exactly. And they're in tears, right? Just in so much pain and searing, burning sensations down the legs, front, back, all over the place. Yep. So as we progress on from we're just stiff in the morning, how do we start to, or what is causing these escalations in pain? What might these acute injuries look like?
My take, and here's the hot take, is that it's actually the same injury most of the time, right? It's mostly a discogenic problem. All that stuff fits a discogenic problem. And what I've learned is that discogenic issues, especially if someone's like, I have a bad back, or this is my discogenic thing, one of the first things I tell them is I go, listen, discogenic injuries can manifest in different ways from a pain perspective. It can feel like it's soreness. It can feel like it's a soft tissue injury. It can feel like it's, again, like that 220 volt raging pain down the leg. It can be centralized back pain. It could be, I got this hip flexor groin thing going on. It could be all sorts of different feelings, and actually just stemming from the same cause, which is a discogenic problem in the lumbar spine. I think
just define that term for me. What do you mean discogenic?
So just the disc in general, like the disc is a highly innervated structure that's in a position right next to the spinal cord, right? The typical thing that most people think of when they think of discogenic back pain is herniations, or basically it's 90% fluid, right? It's a hard, and again, the reason we use the jelly donut analogy that everybody freaking hates, because it doesn't move that way. It's the best way a disc looks is an undercooked scalp. That's probably the best analogy I've heard.
Right.
An undercooked scalp. So if you think about an undercooked scalp, if I push on top of it, it's got give to it, right? But it's also pretty stiff. And what ends up happening is I push on one side of the disc. So I push forward on it on the front part. It's gonna actually bulge on the back side of the disc. If I push on the back side, it's gonna bulge on the front side. This is very, very, very uniformly received research that's how discogenic movement works. The nucleus in the center, right, moves like a water bed. If I stand on one side of the bed, it's all going to accumulate to one side. If I move on this side, or vice versa. Yeah. Where the research has kind of been debunked is if there's a tear in that disc, like the jelly donut, and the jelly goes out of the donut, the jelly's not going back in the donut. It doesn't work that way. But what people have used is, that's why so-and-so McKenzie exercises or all these things don't work. And the reality is, I tell people in most scenarios, if you're in that situation, now you're in a surgical situation, or you're in a different situation where, these exercises aren't as effective. Doesn't mean that you can't get out of it. However, this is the holy hell, I'm in excruciating pain type of situation. 90% of people, in fact, I would even argue 98% of people, aren't usually in that scenario when they get to a physical therapist, generally speaking, right? So to go over like the back pain, I think of the, I'm going to interrupt this thing because I think of the one client of ours, what we had, and I think I remember turning to you, we were at Red Bull Arena, there was a professional soccer player he had, and to talk about different ways that it manifested, he had a calf injury once for the national team. It kept reoccurring. Then all of a sudden he had a hamstring injury on the same side. Then he had a calf and a hamstring. And I remember, I think I even told you, I was like, I feel like it's coming from his back. That's the type of thing where, and by the way, on an MRI, confirmed, right? That it was these things. And I remember once we were talking, you were like, hey, they're digging around in here with the ultrasound. Like, we can find these grade ones, particularly professional athletes. And then you remember there was one game, I remember us standing next to each other, his back, he was fucked. He was like in that situation where he's in agonizing pain, and he actually had pain down the legs. And I had him lie on his stomach, and I was like, how are we feeling right now? And he's like, it's better. And I think I turned to him and go, this is going to look ugly when he gets back, when he gets up, just so we're clear. Like, it's like, because now we're centralizing symptoms, and that shit hurts. Go ahead.
That's the funny thing, because I vividly remember those conversations, and us both being like, like, why are we ultrasounding his calf? Like, we know this isn't that. And I always joke with people. I've had several people come to me with very acute backs. I'm like, look, this is going to sound ridiculous, but my goal here is for your back to start hurting.
Yes.
And not your hamstring or your quad or your groin, right? Actually see it as progress when you have back pain.
Yes, exactly.
Right? And you won't like it, but that's what we're trying to do.
For sure. And I use the word, I know this sounds counterintuitive, but we're trying to be back, right? Or the best case scenario, we're going to make it better, right?
Yeah.
And I think the idea behind when so to go back to your question about how does it happen where I'm stiff in the morning and then I have the event and I go, when I pick the thing up off the ground and then I have pain in my back or I have another issue that goes down the leg. This is an indicator in some capacity of maybe the severity of the discogenic problem. But the more that I've done this, sometimes I also disagree with that statement I just made, is that it may or may not, pain down the leg doesn't necessarily mean the discogenic bulge or problem is worse. And again, going back to that pain science idea, our body might just be interpreting these things differently, right? Why would that professional athlete have a calf injury with zero back pain and be able to run and the power that he had for so long? Then if we rehab it, it gets better and he can go do it again, right? Yeah. And we sit there and there's a disc bulge on his spine, right? Whereas somebody can come and they can say, "Wow, I have excruciating pain down my leg and my foot with some foot drop," and they tell me there's nothing on an MRI that I can see, right?
Well, there's so much individual anatomy as well.
Yes, absolutely.
Right? Like, again, like we're just built differently, and it is, we're not talking about like inches here.
Yes.
In a space where we're all in about a millimeter or two's variance.
Yes.
Like a slight increase or decrease, if you've got slightly more bulge than I do, it's not going to necessarily show up on an image, but I bet you're sure as hell that the symptoms are going to show up.
Oh, and let's also say, like, say I'm the person who is hyperlordotic, meaning I have a bigger lumbar curve, right? So I have somebody like that now. She has a much bigger lumbar curve in her spine, but she actually needs to extend more initially. But eventually in my head, I'm thinking the reason I think her back pain keeps getting worse is because her core strength, her stability, that stuff's not there where it needs to be.
Yes.
So here's the culprit, here's the victim. I think of the disc as a victim a lot of times. So and again, it's a highly innervated structure in a disc that takes a lot of compression, because of gravity and whatnot. And they go through kind of what you're talking about before is, flexion, like you and I've talked about, particularly lumbar spine. We are constantly flexing forward. We're bending to pick something up. You and I are sitting here. You might be standing. I'm sitting in a chair, right? In a flex position. But in theory, like if you are sitting for a long period of time and flexing, that's the problem. Like someone says to me all the time with back pain, they go, "Hey, I'm going snowboarding or skiing this weekend. Am I going to be okay?" I go, "The actual movement of snowboarding and skiing, you should be fine. It's the chairlift that's probably the bigger problem." Right? Because it's the aspect of sitting for a long period of time that's actually the issue. And the reality of it is the severity of the injury typically is because of, okay, I went to pick up this 90 pound of fertilizer. I've had this kind of thing lingering and I've never done anything for it. And this was just the straw that broke the camel's back. I had somebody, they did it with sneezing the other day, right? Like just that's it. Right.
We had in the NHL, we had bed back was our worst. You just stay at a different hotel.
For sure.
Right. Sure. And the guy comes in and his hips are about 4 inches displaced from his shoulders.
Yeah.
Right. And
video games. How many times are the video games, right? Players.
That was NBA was sitting either at the casino or on video games.
Yeah.
We had one guy tying his skates right before we went out.
Yeah.
Just before we went out for warm-ups, he just bent down to do his skates.
Yeah.
And that's something like sitting I think it places huge demands on the body. And we actually talk about training for sitting.
Yes.
Like it's hard on the body. And this rehab that I did recently, we were going through, we actually went from the in tears, like atrophy in the quad, like full on, like disc sitting on the nerve, compressing that femoral nerve. And we were actually making our way back conservatively without the surgery.
Nice.
And then what happened was start feeling good and sort of go back to work and have a day of meetings. And it blew right back up.
Yeah.
So the attention went to what did we do in our rehab session yesterday?
Yeah.
Because there's the fear around moving. What did I do to cause it? Not, oh, I sat for 8 hours.
Yes. And
that being the thing that actually puts the most compressive load on that spine and actually caused the relapse and subsequent, we'd made the decision to go for surgery at that point.
Yeah.
But really interesting the piece around sitting.
Yes.
And how important that is in this whole conversation.
And mainly, I mean, not just for the lumbar spine or the cervical spine in the sense of sitting, but also for the thoracic spine as well. But the idea behind what you just said, I sit for a long period of time and then I lay for a long period of time and I don't exercise or don't move the same way I used to. And then I go to increase that load. That's really what's happening is I am biasing that load more than I'm biasing that particular segment of the disc or certain issue. And then what I do is I go to make the movement where all of a sudden then boom, it drops me. Right. And so whether it's tying the skates, warming up, whether it's picking up the way to the gym, whatever, I tell people it's usually brewing beforehand. And so to me, one rule that I've always used for myself, and I tell most of my clients, I go, if you're active, if you go and you fly in a plane, I go, don't be doing heavy deadlifts the next day. I could just think about it from that perspective, right? Just like live to see another day. I'm not saying after that, give it 24 hours of you moving around. But if you fly back to Europe or you fly somewhere, don't go trying to PR your deadlift the next day. You know what I mean? Like that's just that's just stupid. Like that's asking for a problem. Now, should there be fear around deadlifting? Absolutely not. Should there be fear around traveling? Absolutely not. But those two together just increase your injury risk, right? It's no different. Be no different than if I said to you, Jez, I said, hey man, we got these guys. Maybe we should sprint them as hard as we possibly can today and then do Nordics right afterwards, right? Or vice versa. Right. You'd be right. I like Nordics and I like sprinting, but maybe we don't do them right next to each other.
Maybe they don't live together.
Exactly. Maybe they don't live together. Like, right? Like we can have bad roommates. So it's like, it's one of those things where it's the same kind of concept. It's like, and sometimes it's people don't even understand what's going on or what's happening and that the severity of it. And that can be a certain degree. So yeah, I mean, I think that it can just, it's a combination of improper movement faults, whether it's from a job that they're doing to something where they're sitting more to bending forward. Like again, one that comes to mind is car mechanics, right? They're bent forward over something. And then there's some sort of other vocational thing, whether it's fun of some kind. There's a bunch of different ones. Like I said, we talk about video games or something like that, where you're sitting more. And then it's like, hey, I'm going to go do the thing that I don't usually do, and my body then reacts. And so I think there's that increase in load. It'd be no different than an athlete for a hamstring injury. If it's like, hey, I never trained that hamstring, and then you said, hey, let's go do max sprint. And then boom, it happens.
Exactly right. So that's a great segue into, all right, so now we understand some of the mechanics of what's going on here with these injuries. I believe, and I've seen this play out over and over again, that the fear element is fear of movement is what exacerbates this from being an injury that heals and we move on with our life to an injury and now I have a bad back.
Yep.
And I think back to my dad growing up, had a bad back, just had a bad back, right? Yep. We all know those people who can't do certain things. They won't do certain lifts, won't do certain things because they're scared of hurting their back again, or they think it's still hurt, right? And so I think it's one of those few movements that we don't allow it to be healed and we move on and it becomes chronic. So let's talk about movement then from the acute point of view. You said with the stiff back, 100%. We want to get moving. Let's get that range of motion restored. With the acute injury, for me, movement still is the thing that gets us back through a full spectrum from mobility, but then also strengthening.
Yeah.
Because we become hyper aware of anything like, oh, I did that exercise, I felt my back.
Yeah.
Well, yes, we were working your back. So
Yes.
were the muscles on either side of your spine working, or did you feel a shooting pain down your leg? Right. And so that's sort of what I'd like us to get into now is,
cool.
Where do we start?
Yeah. I think the first thing, so, and I'll tell you what, this is something that I've taken since you and I worked together and some of those things. I think also now I'm 38 going on 39 years old. So I've also made some adjustments in my mindsets. But a great example was like, I woke up this morning with a stiffer back. One thing I've noticed, like I'm having a great snowboarding season this year and like really enjoyed it. But after 2-3 days of doing that in a row, I definitely wake up a little stiffer in the mornings. So one thing I would prioritize for those listening on those types of deals is like, I don't train at 5 and 6 in the morning right off the bat the next day following that.
Yeah.
Will I train later today? Absolutely. Right. It's because discogenic movement and spine, whenever someone says I woke up with a stiff back, but I get moving and then it gets better, whether that takes 15 minutes, 20 minutes, an hour, etc. That's movement doing its thing. And the reality and the reason for why that occurs is because that nutrients in and out of that nucleus that we talked about, that undercooked scallop, takes time. If I am moving and rocking back and forth in different range of motions for my spine, ultimately what's occurring is I am allowing think of like an old-fashioned water pump. I am getting chronic metabolic factors like lactic acid, etc., that are sitting in the discs that are making that stiffness and soreness. I am facilitating new nutrients in and old nutrients out. Right. And so by doing that, I'm creating more nutrition to the joint. I'm creating more blood flow to the area and the discs, and ultimately more hydration. And so that's what's occurring in that scenario. If you feel stiff in the morning, so motion is excellent. Now you add load. So to me, like the morning yoga or Pilates, so when people say, hey, I do Pilates or I do yoga in the mornings, I feel a lot better. My back feels great. Awesome. But here's the only caveat to that, because you're moving in all the different range of motion, but great. You're not adding any load. And so the issue is not adding a load. When you go to garden and you pick up that bag, you just put up, or you go to help your friend move and you pick up that couch, guess what? Now you're not really set up for success. And so the aspect of what I tell people with a stiff back is you want to learn what motion. For most people, it's extension, but there's all sorts of different range of motions. But ultimately what you want to be doing is you want to make sure that your spine's moving in all those directions: flexion, extension, rotation, left to right, and then side bending, and even that side gliding. So you want to make sure you have good, solid motion in the spine, from the cervical spine, thoracic spine, lumbar spine, and SI joints and hips. If you have that good motion in that spine, generally most people, if you go from stiff to not stiff because you moved all through that motion, you'll see a big difference. Now, obviously, core strength and the back musculature you're talking about, I consider as part of the core. Some people just think of the six pack when I think of the core, but I think of 360 degrees, right? I think of the obliques, internal and external obliques. I think of the QL. I think of the paraspinals, lumbar spine. Exactly what you're talking about. Those things are meant to get like sore. And a great way that I can tell people if you're sore in your back, I go try foam rolling your back. I go, if you're like, oh shit, as you're going on the foam roller, it's probably soreness. That muscle is probably sore, right? Exactly. If you find that you're like, I'm stiff, but like I'm hearing pops and cracks, and like that's what it is, it's probably more discogenic to the facets and joints that are just creaking. Either one are fine. It's not a big deal. I think the progression then of strength training and mobility that's important there is, I'm such a huge believer in everybody squatting with load and everybody deadlifting with load. Obviously properly prescribed exercise is huge, right? That's a monster. So that's where people can get in trouble. But that to me is a big piece of injury prevention down the road, for sure.
For sure. And I think whether it's a squat, a deadlift, or any of the other strength training exercises, these are destinations.
Yes.
This is not, okay, you hurt your back yesterday, let's get deadlifting.
Totally.
Right? I think building up under the correct coaching from where you are, we've got a stable, not only is the core 360 degrees, it's also multi-layered coming all the way into the spine.
Yes.
And so we've got to really work from those deepest layers. And I love what you said earlier about the legs are actually the shock absorbers.
Yes.
I think of that for every joint, right?
Yeah.
As we get weaker, the joints become the shock absorbers,
Totally.
right? Your knees, your ankles, your hips hurt as you get older. Yeah, because you don't have any quads, you don't have any
Yeah.
glutes, right? So if you can't bend at the joints, it's like you take the shocks out of your car and just ride around, right, on the wheels, right? So
Exactly.
you
Good
same
analogy.
with your spine, right? Absolutely the same. We've got to strengthen those muscles of the spine, the paraspinals that are the deepest layer, and then out into those spinal erectors, the two big bands of muscle that go all the way up the sides of your spine. If you're pretty symmetrical in your soreness and it's quite superficial, like you said, you can press on it either with a foam roller or if you get a massage, you feel both sides.
Yes.
Your muscles are sore, and that's the necessary side effect of strength training.
For
We
sure.
need them to get sore so that we can go to that next level.
For sure.
I've seen over and over at the prescription of rest, and I saw it in sport with all sorts of injuries. It is actually what makes you have a bad back for a long period of time, because you just get weaker and less stable and more prone to injury because now you don't have any shock absorbers.
Totally.
So
Totally.
I really, I think the value of muscular strength for back pain is just massively underrated.
For sure. And let me go through that process, because you just talked about that too, and going kind of like the pain cycle and I have the bad back, etc.
Yeah.
What ends up happening as a cycle, in my opinion, we don't understand what's going on. I have the stiff back. And by the way, I know I've had it. I know you've had it. When you have that like true discogenic event that puts you on the ground,
Yeah.
it's fucking terrifying. Listen, I
Yeah.
know what's going on, and I
Yeah.
was like, holy hell, like it's crazy, right? Because it is scary and it's
Yeah.
bad, it's painful.
Yeah.
So to me,
Doesn't lived experience just make you such a better practitioner?
I believe I remember reading this article when I was like maybe a year or two out of school, and someone was writing, "Hey, me having all these injuries has made me a better practitioner," and I could not agree more with that that article. And so exactly, like I tell people all the time. I go, I remember one time sitting in a car, I was driving around treating people at their homes at the time. This is when I first starting our business, and my left hamstring was super sore, and I was like, God, I deadlifted that morning. I was like, God, deadlifting. I was like, my left hamstring is really sore. Why is it sore? And I went, wait a minute, why would my left hamstring be sore, not my right one?
Yeah.
And then sure enough, I like did some press ups and the soreness went away. And I was like, oh, it's my back.
Yeah.
That's what's happening, right? So I think to your point, one easy way that people can look at it is usually if you have symmetrical soreness in the back, in the butt, in the hamstrings, in the quads, in the calves, typically that's probably coming from an exercise you did, especially if you exercised the day before. When it's unilateral, like it's on one side, like my right hamstring is sore, my right back, right in those areas, I always do the PSIS, like just above that bony point, my SI joint is sore. That's typically when the back is like kind of giving you the warning signs of, hey, there's something going on.
Yeah.
Right. Yeah. And so for the most point, I think what happens is we wake up with this stiff back. I do a movement that has this back injury. Somebody says, oh, you shouldn't have been doing that. That's why your back hurt. And then ultimately what ends up happening is I don't want to do that. And because I don't want to do that, you now hurt yourself again more frequently. You increase the frequency based off of the rest that you talked about. So now what happens is not only do we tighten that pain loop, we just keep reinforcing it. And then on the top of that, what ends up happening to the central nervous system as we do this, to go deeper in the pain side, I'm going to make it very elementary for you have somebody that has a pain science background, is I use it like a stereo, right?
Yeah.
Normally walking around, say the dial of a stereo goes to 10, and I'm sitting here, you and I right now are at a 1. We're going to use 0 as your dead, right? So 0 is the dead. So we're always walk around around a 1-ish. Well, if I have that loop and I have that first injury, what ends up happening is my dial got turned from a 1 normally sitting here to like a 7 or 8, right?
Yeah.
So I'm going to feel pain more than I should. I'm going to feel it come on faster than it should, and it's going to last longer than it should. And so that's where we get into this chronic back pain argument. And ultimately what occurs is then if I start to have this happen more and more frequently, that elevated switch is going to stay elevated. It's going to stay at a 5, 6, 7, 8 all the time. So I'm more likely to get hurt on a regular basis. And that's chronic back pain in a nutshell. So what ends up happening is instead of removing that pain, it's psychologically downloaded into your brain. And by the way, there's actually now research that comes out that they believe that like that's where have you ever heard of like complex regional pain syndrome and some of these things? Like this is where they actually believe it actually even gets downloaded like in your legit brain, like in the homunculi of your brain. And so then it becomes very physiological. Like I tell people, you're not crazy. If you didn't read anything from Dr. Sarno, it's like, you're not crazy. However, we need to rework this, the somatic, autosomatic, all these different pieces of your brain of how your body responds to pain. And so ultimately, that's why movement is so essential, particularly if someone has acute back problems. I tell people it actually should be easier to fix long term because you haven't learned any of these bad chronic problems like my bad back, right? And so that allows them to be more receptive psychologically as well. It's like, here's how we can remove these steps. Like going back to my patient who's like, it's a structure, it's a thing out of place, it's a blah blah. Eventually, I was just joking where they go, there's that structure thing again. You're saying like on the fourth visit,
right?
I was like, it's not out of alignment. We just got to like work on the strength and stability. We got to increase the range of motion, and we have to increase your body's command of that strength through that new range of motion we're creating. And as we do that, that's the injury prevention in a nutshell. But that I think some clinicians make the mistake of going there too fast and go too fast too soon. And then what happens is you light them up again. And now I just create, and now guess what I just did? I just shot myself in the foot as a clinician, because what ends up happening is now the person did get injured in rehab, didn't get better, and they see, I told you. And that's the issue. You gotta, like I've learned with chronic back pain, you just gotta move super slow. It's annoyingly slow, but you gotta move slow.
I couldn't agree more. Now that I'm out of sport and working in the general population, I'm taking on a lot of very complex rehab cases, just because the experience with athlete just lends you to a wider set of experience and how to progress people. And over again, the people that come to me have gone from the physician, and it's been a rest-based protocol, combined with injections and maybe surgeries, but interventions at the medical level, and then to their trainer. And the trainer has gone right to more advanced movements. Oh, you're a golfer. Let's start some rotational movement. And the thing that stood out to me the most is that there is very little progression from the physician through the physical therapist through the trainer. Often it's more from the PT to the trainer, where I think there's a gap. But we must progressively build upon these layers of strength. We can't think, okay, this was pain-free this week, we can go right to the next level. We've got to actually build some strength within that and make progress, not just, oh, did it hurt? Like it not hurting is the first goal. It actually being strong and having some capacity, some endurance. Those are markers that we have to check off so that we can now start going to those higher levels of rehab.
I totally agree. I think there's a couple different factors that play into that. There's a lot of different people who believe in different ways to treat spinal pain in general, back pain, neck pain, maybe, however. I think we all have a tendency to talk shit on one another. That's the other problem. As far as we've talked about this as how strength conditioning specialists, how, and strength conditioning coaches, and how physical therapists and athletic trainers and MDs all talk and work together in a multidisciplinary, capacity. On the flip side, I think the other capacity of what ends up happening is, I remember when I was taking my OCS and studying for it, the easiest of all the study guides was actually the lumbar spine. And I remember thinking, I was like, the reason was because the research is so thin, there wasn't much to think about. There wasn't much on there. And so the problem is the lack there of knowledge, understanding, and research. And you're getting into murky waters in terms of pain science and how do you study this and how do you look at this. So I think it becomes part of that problem. And so where I tell people, like when you're talking about general population, professional athletes and so forth, it's earning that trust, going slow, making sure that you don't have massive setbacks. When you do, making sure that, because now if you have not built those first levels of trust, it's going to be a problem. And look, I had it happen just the other day where like there's a person who like has had 20 years of back pain, got my name, drove far to come. And again, here's where then it becomes always a conundrum for me. They're getting in a car and driving 45 minutes to an hour to come see me. And now we just talked about sitting. They're sitting the whole time. They're hurting themselves. I do all these different things. They feel good. And I say, how do you feel? And then they go back in their car and they get home and they hurt. Right. So it's such a conundrum. I've had people come from Brooklyn. Like I've had people come 2.5 hours, 3 hours to come see me. And I'm like, stand on the train. You know what I mean? I'm like, because what ends up happening is, if you don't explain that enough and don't get down that rabbit hole and explain how that all works, you're going to have issues with that. And I think it's such a fascinating topic because, I think that in medicine in general, there's so many different opinions of how it should go and not go. And why that's a problem in terms of the handoffs, like you were talking about, and not enough communication. It's exactly what we're trying to fix in evolution, right? Is bridge the gap between rehab and performance. Like, how do we keep that tighter, just like we did in pro sports and still do?
Yeah,
it's essential, because if you don't, and you expect, oh well, they'll just continue on what I'm doing. Yeah, maybe if it's an ACL rehab, because there's a ton of research around that. If you refer to somebody who's solid, like, I'm pretty confident you and I couldn't say a word to each other if I just said 6 months out from an ACL and I handed you some objective measures where we're at. You're probably going to take it in a direction that I know you're going to do it. Exactly. Got it. Know where I'm going to go, because you might do additional stuff, and vice versa, because there's miles and miles of research on that. With back pain, there's so many people that can go in so many different directions still. And they can have these different conversations, right?
Because of the complexity that you talked about in the joints themselves. Like the knee goes one way.
Exactly.
Right? Like people get hurt, and I'll tell them all the time, man, I wish you'd just torn your ACL.
Yeah. Yeah, exactly.
Sounds really dramatic because it's a big, scary thing, but it's such a step-by-step process.
For sure.
Like with this stuff that we're talking about, it's very complex. And I really want to touch on a point you made about the multidisciplinary team, where everyone wants to talk crap about one another.
Yes.
Right? The physician, the AT, the physical therapist, the strength coach, the personal trainer, whatever that mix may be. Everybody sees themselves as competing. And the doc might say, no, the strength coach shouldn't do a deadlift with you. And then the strength coach might say, no, that the doc should never do an injection. The doc should never have you rest. And it becomes a separate system when all of these modalities are needed in their place. Right? If you get the 220 volts down your leg, you might want to rest for a week.
Yes, exactly.
Exactly. You might want to let that thing calm down. Maybe it'll be important to have an injection. One of the gentlemen that came to me had 5 years of sciatica. We did some conservative management, and he went and got a shot in the joint. And his was really interesting case. He got that shot in the nerve root. It reduced some swelling. We kept going with our training. It was a part of our program. And it was transformational. It was fantastic. But
for sure,
because we were working with the physician, not saying, no, don't ever have anything done to your spine.
Yes.
All of these things have their place. And I think it's very important to see it as a spectrum. The doc may have you rest and may have a very good reason for that. The doc may recommend an injection and have a very good reason for that. Then you need your PT. Then you need your strength coach and your trainer. But the communication on where they are and what they're ready for, like you said, if you handed me an ACL, you would say, here's the objective measures, and we're at 6 months. And so I would know what to do.
Yes, exactly.
Right? That's the important piece, is that you need to have a team and see this as a full team that works with you at different levels of your rehab. So you're with your doc, and your PT really is get pain-free, right? Start to get the ranges of motion reestablished, start to do some corrective exercises, get out of pain, get that base level of strength. Then we're moving on to your next levels of training, but it's not right back to deadlifts.
Yes. Yeah.
Right? That there are steps. You've got to bridge these gaps and maintain some control. Can you now move with really good control? Can you do some of these movements unloaded and control through that motion and start gradually adding load to all these different segments?
Yeah. And I would even argue that, if I'm having somebody who's got back pain and they're coming in, and I think of one of the worst back injuries that I ever had, I was deadlifting 4 days later. And so to your point about like, should I have been doing that? We could have a debate on that, right? But I think to your point about being like, hey, they're just coming off a back injury. They're looking for this. let's go through a GPP phase. Let's go through like a general preparation phase. Let's actually go. Maybe it's not this time to be like, you know what, I'm going right in that power phase. I'm picking right back up to where I was in my program. It's like, that's why I think it's so important for that conversation to occur. And your point about like injections versus like medications, like I've had the same exact experience where people could have, you know, a dose pack, a steroid pack of some kind, a cortisone injection of some kind, and have a transformational change, because what ends up happening is we're taking pain and we're putting it in its own bucket. I say this to people all the time. This is the continuum I tell people. I go, one is we're going to fix your pain. Let's work on your pain. And what we're going to do is we're going to address the problem as well. Sometimes by addressing the problem, we address your pain. Sometimes we don't, right? An ACL is a great example. Guess what? We just reconstructed your ACL. You know as well as I know, those first 10 days suck after that ACL.
Yeah.
But Brian, my ACL was torn and I had no pain, and now I have my ACL done and I have tons of pain. Well, yeah, that's a different bucket, right? There's inflammation, etc. So pain and problems don't necessarily go hand in hand. Sometimes they do, right? I have back pain, I do press ups, the pain goes away. Fantastic. Like that's a synergy link. It can work that way. Once you fix those, we've addressed the problem that was causing the pain or not causing the pain, and we fixed the pain and the problem. Now we can move on to intervention. Let's move on restoring normal, right?
Right.
That can be done either in physical therapy, it can be done with strength conditioning, it can be done in a combination of both, etc. Right? Where now I'm moving well and I'm strengthening all the different parts of the body where I need to work on that. And then the last piece is performance. Now we've built the foundation. Now we can talk about let's strength train with a purpose of a goal in mind. So I want to be a high level athlete and sprint. I want to be able to throw a javelin. I want to be able to, work out regularly without back pain. I want to get involved in CrossFit or high rocks, whatever it is. Run, triathlete, right? So to me, those 4 levels are super important. And I think it's understanding how that continuum works is very important. That to me is a piece where that communication needs to be, anybody can be involved in those processes.
Yes.
However, that communication isn't very good. You can't move seamlessly through that component. I think what happens a lot with back pain, and we talk a lot more about back pain than any of the other ones like thoracic spine or cervical spine or the SI. But when it comes to discogenic problems in general, I see a lot of people jump to injury prevention to address the problem. And that's where I think the problem really happens when you hear, I tried physical therapy in the past, but I didn't get better. It's like you have to understand what the problem is and adjust. And so therefore, if you find yourself losing patients, if you find yourself having people that aren't getting better, or they're getting better and then they get worse again, that's where I think the other aspect is checking your ego, right? We've always thought about this, you and I, in terms of that, is like if people are being married to a system that isn't working, that's a whole nother conversation in itself.
That's both ends.
For sure.
That's practitioner and patient.
100%.
When we have a layoff, we must reassess where we are, right? When you hurt your back, understand where you are in this process before you think, okay, I can go right back to training because my back doesn't hurt now. I can go right back to where I was.
Yeah. Just
take your foot off the gas a little bit. Don't get a setback. That's the worst part you can have. Like, have the injury, fine, but don't get a setback. Don't drag this out for longer than it has to. Yep. That ego piece is huge on all aspects. It's the practitioners respecting one another, knowing that we're experts in our domains, and respecting, I can hand this off to you now to do your part of it. And we can keep going back and forth. But then it's you as a patient, when you hurt your back, really just making sure that you are respecting that process yourself.
For sure.
Communicating with your practitioners, listening to your body, most importantly. Just respecting the process, knowing your body, knowing your own tendencies. Like my tendency is to push. That's part of being a rugby player. We've got to respect this process, let the tissue heal, and then get to it. And on that tissue healing piece, one of the questions I get a lot, Brian, I'd love your thoughts on. When we get those big back injuries, right, and we can see the disc is sat there on the nerve, right? We're starting to get like atrophy in the muscle. It's a genuine nerve impingement issue. What's the timeline on decisions around surgery there? Like, how long can that nerve be compressed before there's lasting damage, or is that really variable? Or, what do you think about that?
Great question. So it's hard because, all right, so here's what I'm going to do, and I might get crushed again comment wise here. So that's what I'm thinking. So
I'll turn off the comments.
Yeah, no, bring them on. Bring them on, by the way. Bring them on. It'll go more viral. I like it. The general rule of thumb I have heard from most neurosurgeon is 9 months. That's the most I've heard. Is like 6 to 9 months. You really got to push more for that, right? So that's there's the we won't get any comments on it, right? The answer. The complexity around this topic, in my mind, that is just a very simple answer to a more complex region. I think it's very variable. I'll give you a great example. I had a competitive Olympic lifter. She is really strong. She's won tournaments. She's somebody who's got like, a almost 400-pound back squat to her name, and she's probably 155 pounds, somewhere in that range. Like she's a very, very strong individual, right? Has like almost a 220 pound snatch, somewhere in that 100 kilo range, right? She's in that 80 to 100 kilo range. And she had a back issue, left quad. Sort of like you were talking about the femoral atrophy, right? To the point where she was having weakness. And the surgeon was saying the same thing. Hey, 6-9 months lasting nerve damage. And we kept talking about it. She's somebody who, I don't want to call her a sensitive individual, because she is decently tough. She's gonna say if she ever does hear this, she's gonna come back on me and say, "You said I was tough. I knew it." She's one of those patients like, my God, you're kind of sensitive, right? She's somebody who is what I would actually call, if in a clinician perspective, a slower responder.
Yeah.
Meaning that when she's doing the exercises, she responds slower than the person who does one movement and the pain's gone. Those are fast responders. And there's not a lot of research on this. That's why it becomes a little bit more debatable. I'm going off an anecdotal piece of like my kind of experience. That person took about 1.5 years to get back fully. There's an argument there she should have had surgery. However, my argument to her was, if you go down the surgical route, the issue becomes we're totally monkeying with the central nervous system. There is no guarantee. There's no guarantee that what things we do will fix the problem altogether. Your career as a competitive Olympic lifter might be done, right? That might be it. That is possible. I've had other people where 3 weeks in, excruciating pain. They've had no issues. I tell them to go to surgery because we can't fix it. We can't even touch it. They go and do surgery, and then they have more complications. I can proudly say, and again, like, I don't know if I have this like special ability with spine pain, but in general, in the last, I don't know, 6, 7, 8 years being a clinician, I've been a physical therapist for about 15 years. I've probably sent 2 or 3 people to surgery at the most. I can think of that one, and she had to have multiple surgeries, now has seizures, had central, like the surgery fucked her all up. And not to call it the surgeon, I think the surgeon's actually done good work with other people.
Yeah.
But that we're monkeying around the cervical spine, I think, or the central nervous system, right? And I'm a big believer, and I've said this, I do feel like 100, 150 years from now, we're all dead and gone. People are going to look back at what we're doing with spine surgery and be like, oh my God, you remember what they were doing back in the early 2000s? Yeah. Like, I truly just believe that's what's going to happen. I just feel like it's not neurosurgeons, trying to hurt people. It's that we don't know enough. We just don't.
I think it's an important point, like on the conservative management side. Now, the gentleman that I saw, we went to 6 weeks of conservative management. He had that recurrence, and he went and had surgery. And phenomenal outcome.
Awesome.
Phenomenal outcome. Yep. Like, again, very structured. Like, we put a pro athlete return to play protocol around him with exit criteria and progressions and all the rest of it. The surgeon actually looked at it and was like, I just want you to walk.
Yes.
So let's do this. Right?
Yeah. So let's touch on that process. So that to me is a huge piece that I would say, right? Yeah. I would say in general, if you have surgery, you need to not be afraid. I just want you to walk. I just want you to do this. We have a very typical problem. around back surgery, don't do X, Y, and Z, that process. I actually think that's the main reason I think that back surgeries aren't successful, is when there's not again, imagine that'd be the equivalent of I tore my ACL. Perfect. I'm going to fix your ACL. I just want you to be able to walk. Like, we would never, of course, all the rehabs would be terrible. No one would go back to sports, right? So the same exact, why do we do that with back pain? I've never understood that. So it's one of those things where it's like, so to go through the physiological side of it, I think it's more the rebuild that's super important, whether you have surgery or not. I do that weightlifter I was telling about, she's now competitive again. It took a good year and a half to get back. She does have what is interesting is sometimes the reflex is a little off. So there is like a quote unquote little bit of nerve damage, but she's just as strong. If you look at force plates, like she's normalized. And then the difference was down the road, she did have another back injury to the other side that wasn't nearly as bad, and was much better. Pain, I think, is a bigger guide to me when it comes to surgery than it is like the risk of nerve damage. That's my take on it anecdotally. I know there's a lot of neurosurgeons who are gonna argue with that, but that's just, I've just seen enough back pain and had enough positive outcomes with injections and conservative and medication and conservative physical therapy versus surgical outcomes. And I just think that the idea of surgical outcomes, in that scenario, you just talked about one of the better stories. I worry sometimes long term, but I think if that person personally continues with you for the rest of their life, they should be okay.
So that's an important piece. Is you've said a couple things in there that are really important. I think there's you mentioned somebody having another back injury and it not being as bad. A lot of people would go right to, I've re-injured my back.
Yes, totally.
We have to allow the injury to have been healed. I get people to a point in the rehab where I'm saying, okay, you are a perfectly healthy individual who's just getting back in shape. If you get another injury, it's a new injury.
Yep.
Right. We have to psychologically not be like, oh my gosh, I've re-injured my back. It's happened again. It hasn't. It's new. This is important because it allows you to keep going with your life.
Yeah.
Right. It allows you to have the confidence to say, oh yeah, no, I am healthy now. It has healed. It's important from a chronic pain standpoint that you're educating your nervous system that the tissue is healed. I am no longer injured. The other piece is the rehab, the surgery. Surgeons will have sports stars jerseys all over their walls, and the doc saved my career and all this sort of stuff. The team saved your career.
For sure.
Right? The doc did the surgery. That was his piece. The rehab is what gets you back to doing what you were supposed to be doing, what you want to be doing. So to your point, the long-term outcome is determined by, did you do the work to get back?
Yes.
Did you do the work for it to heal? Did you earn the right to say, I am a perfectly healthy individual. Now I'm get back in that performance phase and I'm getting back to return to performance stuff. Now we've got a good outcome.
For sure.
As far as the surgeon was concerned in this case, if he went back for a 6-week check-in and he'd been able to walk up and down his street, job done. We've done a great job here.
Yep.
That's not accounting for 5, 6, 10 years down the line.
Exactly. And to me, what I tell people, generally speaking, and again, it depends on the surgery, whether it's a discogenic, discectomy to laminectomy, fusion, et cetera, all the different variables around there. One is that we're also, again, monkeying with the biomechanics of your spine.
Yeah.
So now all of a sudden, and I have somebody now who had a back surgery, didn't finish the rehab process well, didn't do it well, had the pain go away, everything went great. 2 years later now, he's clearly have what I would call a adhered nerve root, really bad neuromobility issues, to a point where when I put him in very specific situations, it hurts, to a point where that's why he had pain when he was walking, had a drastic increase, had another new injury, and he's like, oh, and you can see now what happens is, oh my God, I'm going to have to have surgery again. Oh my God, I'm going to have to do this. And for him, my biggest thing is I go, listen, we got to build this foundation. We got to fix all these movement faults. We got to increase your strength. We got to get you back to where you were. and then we're going to get you back into these fitness programs, and that's going to be the thing that prevents your injury down the road. Do we rush that? No. And so you can do that after surgery. Not a big deal. You can do it. I personally think it's better if you do it before. And
Likewise.
yeah, exactly. Most people would. And it's a similar boat. Like just kind of talked about, it's got to be fix this pain, work on this problem, address it, prevent the injury, and then work on strength training to really perform. And again, I think the nerve damage thing. Well, to me, the bigger problem around the nerve damage talk is more of almost, I see it used more from a perspective of fear, right?
Mm-hmm.
If we don't do this, you could have nerve damage.
Yeah.
And the problem in my mind with that is I don't want to say it's not true, because of course, if you let it go long enough and severe enough, there'll be nerve damage. Of course. My experience is you can fix most of these before you get to that point, even in some really heinous cases. So, and by the way, the ones, I don't wish this on anybody, but the ones that I have seen go into that more nerve wasting have been some sort of horrible chronic stenosis, kind of like what ended Archie Manning Sr.'s career in football, or ALS. I've seen that be misdiagnosed, and all of a sudden, oh shit, it's actually ALS. I think you get more of that than anything. When you see some of these other more sinister things. And those are just rarer. I mean, I don't want to say they don't exist, because of course they exist, but you do see, and again, I think genetics plays a little bit more into that. So I typically look back into what's going on there, but that's more what I would say on that front. I'm usually the guy being like, well, hold on, let's slow this down.
Yeah.
Let me talk you out of surgery. I get the people who are talking about it. Let's try and do this process first, and then go from there.
Yeah. I couldn't agree more with that, Brian. And look, I think the point there is we can fix basically all of this.
For sure.
And so go through the process, move. Don't be afraid of getting up and doing these movements. Don't be afraid of going through these steps. But the earlier, for me, you address it, like day of, the earlier you can address it, with any injury, the earlier you start moving, the better it's going to be in some capacity, wherever you can be at. But like you said early on, it's when you get to it 5, 6, 10 years later, and you've had that pain, now it's a different beast you're dealing with. So I think that really try and get on this early. Movement is always better than not moving.
Yes, I couldn't agree more.
Right? It's just always. The body doesn't like to be in any one position for a long time. Yeah. Right? It's not that we can't be in flexion, just don't stay there.
Yep. Exactly.
You move, get up, right?
And I tell people too, like, think about if you've ever broken a bone when you got out of the cast for the first time and you're like, oh, I'm stiff, right?
Yeah.
That's a normal movement. What is the first thing you do? You start moving. And when you start
right.
moving, you feel better, right? And when I do an initial evaluation, like an intake of somebody, and the question I love asking, I go, do you feel better when you're stationary, or do you feel better when you're on the move? Most people say with their spine, they're better on the move. When you say, I'd rather keep moving, I feel better. Cool. Then guess what? I know this is going to help you, because this is called physical therapy, not lying around therapy, right? So we're gonna move, and we're gonna do better. And usually they kind of, it's a fun joke. It kind of like gets moving, and all of a sudden people are like, all right, good. I can see like this. I go, your body's already telling you that you're going to get better with this, right? When you sit, and usually you can see when someone, like, I go, if you sit in that waiting room chair for 10 minutes, or they're kind of pacing around being like, hey, is it all right if I stand during this eval? I'm like, this is going to go well, because what's going to happen is they're already trying to move and feel better, right? So if you find, even if it's like, hey, I'm afraid to move, you're reframing it, right? You're reframing that pain. And that's so important for pain science. It's not that it's not that movement is causing my problem. It's that I don't know which movements are going to fix my problem. And so when I move around, I feel less stiff. I feel better. And as I get moving, I feel good. Cool. Yeah. That just means that we need to find the right stuff to make you feel better. I tell people it's going to go one of three directions. I'm either going to make you better, I'm going to make you worse, or you're going to stay exactly the same. Right? If you're better, amazing. That's obviously the goal. If I make you worse, it's actually not the one that I'm most afraid of in that outcome of those 3 steps, because it means I just picked the wrong movements, right? Or we
Yes.
picked the wrong movements. So if you get worse with movement, it means that movement actually should be better. You just probably should go in the different direction, right? Or the opposite direction.
Exactly right.
And if you feel the same, that's when I'm like, oh shit, either this is so severe I can't make an impact on it, or I'm in the wrong place, right?
Well,
It's something else.
Exactly. And that's where, again, that cookie cutter, like dogmatic approach comes in. I had a guy, the same guy I was talking about, not the surgery guy, but guy was in pain, sciatica for 5+ years. And I'm thinking, oh, we got this. Let's get some Mackenzies going and we're going to knock this right out. Well, just the anatomy of what he had going on, extension actually exacerbated it.
Yeah.
Right. So we actually had to train him more into flexion. I had to teach him how to get into a bit of flexion and then do the movements.
Yeah.
Like then learn how to differentiate between his lumbar spine and his hips. Right. How did we differentiate and separate shoulders from spine movement? Right. And so, but maintaining a little bit of flexion just to decompress where his mechanical compression was. So it really was just a case of, rather than being like, oh, okay, well, if Mackenzie's don't fix it, I guess he's screwed.
Yeah,
exactly. Go do surgery. Well, no, that was just the wrong movement. Just pick a different one.
Exactly.
Go the other way.
I tell people all the time, and it's just a matter of like sometimes I'll rotate people, I'll shift them, I'll move them all over the way, and that's, I think, the difference on why some of that research is debatable / it's not shown here, it's shown here, is mainly because what ends up happening is, it's such a case by case basis, and what happens is, instead of us saying, hey, this is going to get better or this has been debunked here, it's, hey, this is where we're going to start. This works for me a lot of the way. I'm going to get better. And if not, again, I'm going to check my ego and I'm going to say, let's try this instead. Let's go in this direction. Let's move this way, right? Instead of abandoning shit,
Well, that's it. So again, it's important because, and I'll speak to practitioners here of, well, that got debunked. Well, under what circumstances?
Yes, for sure.
Right. It didn't work under these very limited constraints that we put on this research project, right? Stuff probably works. It's just we found other stuff that works in different circumstances.
Totally.
So I think we can, as a part of the evidence-based crowd, we can get a little bit too quick to throw stuff out and swing on the pendulum like, oh, it was this and we all believe this and now it's this. Well, no, we just added to it. We didn't replace something necessarily, within reason. But
I totally agree.
Yeah, I think that's such an important mindset as a practitioner and as a patient is to not think of it as these separate things that, okay, we used to do this, it got debunked, and now we do this.
Exactly. If in theory we all knew exactly what to do all the time, we'd all just do the same thing, right? You'd never see different shit on TikTok. You'd never see different stuff on Instagram, right? Or YouTube or any of these things. You'd see the exact same thing. We all learned it in school. We all taught everybody the exact same thing.
Yeah.
It was incredible. It's like, it would be like a recipe, right?
Yeah.
But the reality is we're always refining that recipe. We're always tinkering with that. We're always learning something different. We're always cooking something different. So the aspect of it is we're constantly changing that up. Totally agree. And I think that's a component where you think about it from my perspective. That to me is a bigger piece. It's like, what is, and I tell people all the time, I go, if you came to me with this back problem, you're probably thrown out every study that we've ever read on this problem, right? Yeah. Because you got diabetes, or you're a pro athlete, or you're blah, 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 you're this, or, oh, you had ACL surgery in the past. Oh, you know what I mean? Like, like those are all going to be totally different things. We are looking at very, very centralized things in a vacuum. And ultimately, like I tell people, every patient's its own case study. If anybody's ever taken, for the American Physical Therapy Association, some of these continuing education or these certifications like the OCS or SCS or, any of these things, it's like evaluating 200 patients in a row. They actually need to do a good job of like making this difficult, because it's one of those things where you're like, got it, I got to look at this, then I got to look at this, then I got to look at this. Oh, here are these 9 red herrings I got to not look at, right? Like it's case by case by case basis. And that's very important to think of whenever you're going through that process. For sure.
All right, Brian, I've kept you way over time. All right.
Good.
You've been on before, so you know what's coming. We do our 3 takeaways
Got it.
every time. If I'm a general population, interested in my fitness, maybe I have some back pain, maybe I just want to keep a really healthy back. What are my 3 takeaways from the things we've talked about today that I can build into my daily life today to make sure I either get out of back pain, I rehab my back, or I keep a really healthy back?
Awesome. I think that in terms of back pain and the 3 takeaways that I would give to really help, like my top 3, something like yoga is a really great thing for most people. And if someone's like, well, yoga takes 45 minutes, an hour, hour and a half. If you just think about the warrior positions and the triangle positions, the cobra positions, the prayer stretch positions, and just moving in those 5 directions, right? Those 5 kind of movement patterns of, the vinyasas or whatnot, and going through that, I think most people will hit a lot of different range of motions and complexes very efficiently. The world's greatest stretch, if you think about it, right, is very much like a triangle pose to warrior 1 or ball. My wife and your wife would totally scrutinize me for all the things.
Absolutely.
Yoga, right? Exactly.
Yeah.
But like the condensed,
Michelle's actually yelling right now. She's like sun salutations.
Exactly. There you go. Exactly. My wife would be like, "What are you talking? You don't even make any sense. Have you not done yoga before?" But I would say there's like a small condensed, like there's a 5-minute yoga routine in those types of movements that I would say are really, really helpful. And probably one of the other parts of that theme would be work with somebody, right? If you ask me, how can I keep my car running well? I'd be like, well, find a really good mechanic, right? Like that would be a good one. Like work with a good physical therapist, work with somebody like yourself, work with even a chiro, whatever. Like work with somebody in physical medicine who can really walk you through better physical mechanical movements, right? Right. That's probably number 2 that I would say, because the other one's a programming. And then the third is that when you have back pain in general, an episode of stiffness or whatnot, realize that the spine in general is going to respond better to motion than it is going to be rest, particularly rest and medication, particular surgery, that kind of thing. So the aspect of finding a really good practitioner who can help you create that routine for you, and then understanding that, like, all right, when I have a back, this is what I do for injury prevention for my back. This is what I do for pain if I ever have a little bit of stiffness and pain for my back. And these are the people I go see when I'm really having a problem and I can't fix it. That to me would be the 3 takeaways in general.
Awesome. Right. And that resonates with everything that we would teach in our practice as well. And so remind people where they can find you, keep up with what you're doing, learn from you, or maybe even work with you.
Yeah. So we started a company called Evolution Physical Therapy and Fitness. The goal is to change the perception of physical therapy, bridge the gap between rehab and performance, all the things we talked about on this podcast. So evolutionphysicaltherapy.com, on Instagram, on social media, Evolution, I think of Instagram, Evolution PT Fit is the main account, and then _ CT. I'm mainly on the East Coast here. As far as working in mentorship groups and having physical therapists actually learn from us, we do have a group called Physio Growth, the website physio-growth.com. Also have some business flair to it until those people want to help as well. And then for me on Instagram, I'd actually great. I've been thinking of a lot of different social media clips you can put in there. My personal one is BT Wolfe02. And then obviously you can find me on LinkedIn too. So yeah, anybody who wants to talk and interact with me, I'm always willing to chat. So yeah, please don't turn the comments off, turn them on. I'm always looking to get better and sharper. It's why we're all here. Right. Exactly.
Right. Yeah. So, amazing, mate. Well, again, Brian, thank you so much. I've really appreciated this chat and all of our work together over the years. So thanks so much, mate.
Likewise. Love it. Thank you for having me.
An incredible conversation with Dr. Brian Wolfe. Here are the 3 key things that you can take away from today's episode. Number 1, build a simple, condensed yoga or mobility routine into your day. Focus on warrior poses, triangles, cobras, and prayer stretches. Even 5 minutes of moving your spine through multiple directions can have a real impact. Number 2, work with a qualified practitioner in physical medicine. Find somebody who can walk you through better movement patterns and build a program that fits your body and progresses you towards your goals. Number 3, when you have a back pain episode, choose movement over rest. Your spine responds better to movement. Have a daily and a long-term plan for prevention. And if you do have flare-ups, know when it's time to seek professional help. If this episode resonated with you, the best way to support the show is to follow us wherever you listen to your podcasts, leave a rating or a review, and share this with somebody that you think could benefit from this message. It makes a real difference in helping us reach more people who could benefit from these conversations. You can stay connected with us on Instagram, LinkedIn, and YouTube at Vitality Collective Performance, where we share additional insights, behind-the-scenes content, and updates on upcoming episodes. Thanks for being here, and we'll see you next time.